core conversations. And we're very happy today to welcome Dr. Anne Monroe, who is an associate professor at GW and who's the project director for the DC cohort. And she's going to be speaking to us today about insights that she's learned using the DC cohort data. And then if time allows, I'm hoping we'll have time for a good discussion about related to that work. And then if time allows, I can just share some brief insights that we have from our nationwide MaxWise combined cohort related to COVID. So, Anne, thank you so much. And
Sure.
please go ahead.
Okay, great. Thanks for the invitation. I'm happy to be here with you all. And I was asked today to speak about ongoing research within the DC cohort about COVID-19. And I am eager to talk about discussion. I have some opportunity for discussion about research ideas and possibilities for collaboration at the end of my talk. So with that said, I'd first like to make some acknowledgements. So I am the project director for the DC cohort, and our DC cohort team is led by Amanda Castell, who's also faculty in the Department of Epidemiology. She's our principal investigator. We are also supported in all of this work by Brittany Wilborn. She is our senior research associate for the DC cohort, who has been focusing a lot of her attention on the COVID sub-study. And of course by Dr. Alan Greenberg, who is the senior co-investigator for the DC cohort. So a little overview of my talk tonight. I would like to just remind everybody about the DC cohort. I'll talk about a secondary data analysis that we did using existing DC cohort data. I'll talk about some of the prospective data collection that we have ongoing, our COVID-19 survey. I will briefly mention our COVID-19 dashboard, and then we'll have time for discussion at the end. So as a reminder, what is the DC cohort? So the DC cohort is a database of consenting people with HIV receiving outpatient care at clinics across the district. Our database contains information on risk factors such as smoking, alcohol use, drug use, diagnoses, so diagnoses of comorbid conditions like hypertension, diabetes, and hepatitis, in addition to HIV, lab results, treatments, both HIV therapies and non-HIV therapies, and procedures that patients undergo, such as radiologic procedures or invasive procedures like colonoscopy or endoscopy. And so the DC cohort is a citywide initiative. It includes academic, community, and government clinics. It's one of the largest existing HIV cohorts in the United States, with over 11,000 participants enrolled since 2011. And there's a close collaboration with the DC Health Department to improve the completeness of the information that we collect through periodic data linkages. And so, as many of you know, the DC cohort was funded as an R24 resource grant. Our funding cycle for that resource grant started last year, and so we're in the second year of funding for this 5-year cycle. The study did initiate enrollment in 2011 under a different funding mechanism. But in the proposal for this 5-year resource grant, we proposed data linkages in addition to our standard linkage with the DC Health Department. And I just want to mention those briefly because that will come up a little bit later in the discussion as well. So the main mechanism for data collection in the DC cohort is that we receive data from electronic health records from all of our participating clinical sites, those 15 different clinics throughout DC. So that's represented here in that light yellow hexagon that we receive. Demographic information, diagnosis information, labs, procedures, those come from the electronic health records at the sites. And I already mentioned that we do also link with information from HOSTA at the DC Health Department. So that gives us additional information about HIV risk factors that may not have been captured at the clinic, as well as additional CD4 and viral load counts that might have been received at an outside facility, opportunistic infections, statistics such as whether someone is alive or has passed away, and molecular sequencing information for the patients who are enrolled. And so all of the DC cohort patients, when they sign consent to participate in the study, also agree to this linkage with HOSTA. Now, these other 4 hexagons at the bottom, Medicaid, Pharmacy, DC Cancer Registry, and CRISP, represent the data information sources that we proposed that we would link with during this 5-year extension of our funding. So we are in the process of getting information from these other sources that we can link with our DC cohort database to make it even more robust. So this is really exciting and something that we've been working on. So these additional linkage sources will include Medicaid information, such as Medicaid's claims data, pharmacy information, such as whether the patients picked up the pharmacy, the prescriptions that were prescribed by their providers, cancer registry data, such as cancer site, grade and stage and treatment, and then CRISP information, which is the health information exchange from across our region. And so that will give us more information about whether people have been to outside ERs, hospitals, and also provides additional information about outpatient encounters. So I could talk for a whole hour about the DC cohort alone. Many of you may have attended Dr. Castell's talk in the same forum about the DC cohort several months ago, but I just wanted to provide that little refresher about the DC cohort and the different information sources that are part of our DC cohort database. So with that, I'll move into the secondary data analysis project that we have submitted for publication at AIDS and Behavior. So the data that I'm presenting in the next few slides is under review but unpublished. And the title of this study was COVID-19 among people with HIV, short-term elevated risks and long-term changes to care delivery. And in the background of that paper, we discussed that there is a high burden of medical comorbidities among people living with HIV, and that during the COVID-19 pandemic, HIV care delivery has been restructured, and the impact on HIV outcomes of that restructuring is unknown. And so we had 2 objectives with this study. The first was to examine the risk of severe COVID-19 among people with HIV, using a definition incorporating clinical risk factors, and to examine the pandemic's impact on HIV care. And we did this by using descriptive statistics, using data from select clinics within the DC cohort. So one of the first things we did was adapt a schema from a study published by Banerjee et al. In Lancet last year that laid out conditions that were high risk conditions, so high risk for development of severe COVID-19 if someone were to be infected, and conditions that were increased risk conditions of severe COVID-19 were someone to be infected. And I will say that this initial study was performed in a general population, not an HIV specific population. And so in the general population, the factors that were considered high risk for severe COVID-19 were someone to be infected were a BMI greater than 40, presence of cardiovascular disease, diabetes, chronic kidney disease, end-stage renal disease, or hemodialysis. And you can see there's a rather lengthy list of increased risk conditions that were also included in that analysis. And so what we set out to do was evaluate among our participants within Washington, DC, how many individuals would be categorized as high risk for severe COVID if they were to become infected, and how many would be at increased risk for severe COVID-19, and how many would have no increased or high risk. And we used these diagnoses based on ICD-10 diagnosis codes within our database to make these categorizations. And so looking at our results, like I said, I did mention that we have over 11,000 participants enrolled in the DC cohort overall. This analysis included about 3,500 participants because we were using a limited subset of our clinics and because people had to be active as of June 30th, 2019 to be included in this analysis. So it is a smaller subset of our main sample. But you can see, looking at the number of participants in each age bracket, how many individuals were considered low risk of severe COVID-19, increased risk, or high risk of severe COVID-19. And I think notable in these slides is that we have very few participants overall who fell into this low risk category. The majority of patients were either increased or high risk. And, we have pretty dramatic numbers of individuals in this 51 to 60 age group who are in the increased or high risk group. The other objective of this study was to look at changes in HIV service utilization before and during the pandemic. And so what we set out to do was look at the time interval of March to June of 2019 and the time interval of March to June of 2020. And so you can see here on the left side of the bar, we looked at the left side of the slide, we looked at the proportion of active participants within the DC cohort who had an encounter in March of 2019 in the blue bar, April of 2019, May of 2019, or June of 2019. And then we looked at the individuals who had an encounter in each of the same months of 2020. And so we were actually surprised to see that the proportion of patients who had an encounter in the March to June interval of 2020 was higher than that of March to June of 2019, and that it was statistically significant higher in the months of May and June. And looking here on the right side of the grant at HIV, I'm in grant writing mode. The right side of the slide, the right side of the slide, looking at whether individuals had an HIV RNA lab value collected, we saw that in April, May, and June of 2019, a much higher proportion of individuals had a viral load test collected during that time. And so, as a clinician, my own practice is at the Washington, DC VA here. And, what I noticed was that when we switched to telephone encounters, I actually had a better show rate because it was easier to capture patients on the phone than perhaps to have them come in person. So although I found this a little bit surprising that the encounters were higher, it sort of reflected my reality that, like, if I was doing a telehealth or telephone encounter, I actually had pretty much an 100% show rate at all my clinics, and everyone was at home not doing much, or if they had scheduled the appointment, maybe they were working at home, maybe they weren't going out, so it was a little bit easier to catch up with them. But I also found that many fewer people were coming in for labs during the same time interval. The people that I really got to come in for labs during that time interval were individuals where I was worried about their clinical status. So these findings overall in the DC cohort reflect my reality as a clinical provider, but I'll be interested to hear from the audience if others agree with those findings that we had, if they had similar experiences. And then this slide is relatively obvious that during 2019, we found no telehealth encounters, and that many, many, many of the encounters in April, May, and June of 2020 were telehealth encounters. So a big change in HIV care delivery from 2019 to 2020. So our conclusions in this work is that our findings underscore the importance of protecting vulnerable people with HIV from acquiring COVID-19 because they would potentially manifest severe complications. And we hope to protect these individuals through strategies, including vaccination, to protect them against the acquisition of COVID-19. And then we also concluded that HIV service delivery will likely be changed long-term by the pandemic, and adaptation is required to ensure continued progress toward 90-90-90 goals. So you saw the changes in delivery that I displayed in our slides. Of course, that was a shorter time frame. That was months ago. Maybe things are changing back to the way they used to be prior to the pandemic. But I think that telehealth will be sustained. I think that we'll see different modalities to connect with people that will be sustained beyond the end of the pandemic. So again, this is things we could discuss in the end. Okay, so the next part of our work with regards to COVID-19 has been the DC cohort COVID-19 sub-study. And the aims of this sub-study were to measure the extent of COVID-19 infection among an urban citywide cohort of people with HIV, to understand the risk factors and transmission dynamics of COVID-19, to assess the association between adherence to stay-at-home and social distancing measures during the pandemic and mental health symptoms, and to assess the impact of the pandemic on the HIV care continuum and the role of telehealth. So when we designed the survey last summer, these were the aims that we hoped to examine in our work. This is a one-time cross-sectional study. The eligibility is individuals 18 and older who are active DC cohort participants and are able to provide e-consent. The survey is available in English and Spanish. We have 697 participants enrolled as of yesterday, and we plan to enroll up to 1,000 participants in this sub-study. So we have started to link the survey data with DC cohort database data. So we've linked it with age, confirmed diagnoses using ICD-10 codes. Yes, we've started to do, so we've linked age, HIV transmission risk factor, HIV diagnosis date, and AIDS diagnosis date from the DC cohort database. And we're in the process of linking confirmed diagnoses like hypertension, diabetes, hepatitis C, and labs and encounters. So that work is still underway. So the domains of the survey include demographics such as race, gender, household size, ages of household members, medical history. So we collect the medical history from the patient as well as having the diagnosis codes from the DC cohort database, COVID-19 symptoms and testing and hospitalization status, COVID-19 vaccine receipt or reason for vaccine hesitancy, COVID-19 symptoms and testing among household contacts, COVID-19 impacts, things like work status, insurance, housing, HIV care, the patient's own perceived risk of acquiring COVID-19, any stigma associated with COVID-19, anxiety and depression symptoms, and use and experiences with telehealth. So these are some of our preliminary findings. So overall, our sample is majority male and is majority Black participants. A minority of the participants report having had symptoms of COVID-19, and among 257 people who were tested, 181 reported an answer to whether or not they had a positive test, and 58 individuals reported having a positive test, representing an 8.3% incidence of COVID among our sample. Most had received any HIV care since March 1st of 2020, and most had engaged in telehealth. So we also looked at whether we have some data on the uptake and attitudes regarding COVID vaccine. So we're trying to get a sense of how willing people are to accept the COVID vaccine and what factors might be associated with people's willingness to accept the vaccine. So we asked people whether they had received a flu shot, and the majority of our participants had received a flu shot. We asked 259 individuals whether they had received the COVID vaccine. So this question was actually introduced into the survey a little bit later, once the vaccines were available. And of those, 176 reported having received the vaccine. The majority of those had received Moderna. The common side effects that people experienced were pain at the injection site and fatigue. Among those who had not received a vaccine, we asked whether they would, and about 60% said that they would. And the concerns that they reported were concerns about side effects and concerns about wanting to know more about how well the vaccine works. So using this COVID sub-study data, we have several other analyses in progress that link back to the aims of the survey that I presented a few slides ago. So the analyses in progress are the attitudes regarding vaccination among our cohort, the social and mental health impact of COVID on people with HIV in our cohort, the impact on the care continuum and the use of telehealth, and that is being co-led by an investigator at Georgetown University. And then we still need to do our just basic paper about the incidence of COVID among our cohort. So those are some of the analyses that are already underway. And then we have some other grant applications and concepts that are in progress right now. So I'm going to be applying for a Robert Wood Johnson Foundation grant looking at the impact of telehealth the impact of changes in telehealth policy during the pandemic on HIV outcomes among Medicaid recipients in our cohort. And there are the other projects underway. Dr. Castell is taking the lead on vaccines among people with HIV and short and long-term immune responses, and genomic sequencing of people with HIV who got infected with COVID. Then that would be performed by Dr. Jean Jordan's lab. So these are some of the ideas that we've been floating and working on using the resources that we have available through the DC cohort. Okay, I want to briefly touch on a couple of other things that we have in progress but have not necessarily reached their full potential yet. So one of these is our DC cohort COVID-19 internal dashboard. So this would be available to site investigators at our different clinic sites. And so this would allow the data that comes in from the sites, we would identify COVID-19 related diagnoses in that electronic health record data that comes into the DC cohort database, and then present that in a way that the site investigators can view their own clinic's data with regards to COVID-19. So we used an ICD-10 code indicative of SARS-CoV-2 infection to document this exposure within the dashboard. This is still preliminary, and we're doing some data validation work with the sites to make sure that the ICD-10 codes accurately reflect the reality, that it's not, for example, that these codes are being used to order a test. We're trying to really figure out how to make these codes reflective of actual cases of COVID at the sites and not just having had a test, that perhaps might have been negative. So this is something we're working on. We think it'll help us get a better sense of how many people within the DC cohort have actually had COVID, but still is not ready for prime time, needs a little bit more validation work. Okay, then given the opportunity to talk this afternoon, I just wanted to briefly mention another new initiative within the DC cohort. It's not directly related to COVID, but I just wanted to let this group who is interested in this clinical research know that this is happening within the cohort. So after our success with the COVID survey, we have also rolled out additional primary data collection with our DC cohort participants. So this is called the Patient Reported Outcomes Survey. And we are asking patients about mental health symptoms, substance use, stigma, medication adherence, and sexual risk behavior. So these are standardized instruments that have been validated for use among people with HIV. And so what we're hoping to do with this information is use what the patients are reporting to augment the data that's available within the DC cohort beyond just the medical record information. And so as of yesterday, we've enrolled 55 patients in this effort. And I'm really looking forward to having this information as a new data source to augment our DC cohort analyses. So with that, I'd be happy to open things up for more discussion. We can review any of the information that I presented or talk more about the survey or the secondary data analysis. And thank you so much for your attention.
Thank you so much. That was really great and so interesting to see the data from our own backyard. So thank you for sharing that with us. I'd like to open up to anyone who has questions related to the data, the information that I think very interesting. Look forward to seeing that publication coming out that looked at, how our HIV care and management shifted during the pandemic, which I think is really gives us so much insight into what we may be doing okay with and where we have gaps. Any questions from our really pretty large audience today? Thank you all so much for joining. I saw people coming in as Anne was presenting.
So I have a quick question. Congratulations on this work. It's an extraordinary amount of work in the last year during the pandemic, and really beautiful evolution of some just great ideas. You mentioned that you're submitting the grant that's going to look at HIV outcomes with telehealth and the Medicaid patients. Will you be looking overall at viral load outcomes within the DC cohort during this period of time?
Oh, you're muted.
Sorry. Within the DC cohort population, about 40% of the cohort have Medicaid. And so the Robert Wood Johnson Foundation grant is really targeting the impact of different policy changes during the pandemic on Medicaid recipients. But certainly one of the things that we're interested in looking at overall is within the overall cohort is the impact of the pandemic on HIV outcomes. And, you know, the viral load data from the period of the pandemic is something that we're working with the Biostatistics Center at GW to incorporate. And so far we have the information from 5 of our DC cohort sites, but not the complete cohort. But here we are, you know, we were talking today in one of our meetings, you know, it's almost time to get ready for CROI again. This is certainly something that might be of interest to a larger audience, and, you know, it's something that we haven't been able to examine yet because of the transition of data within the DC cohort into the Biostat Center, but definitely something that we want to look at in the entire cohort. And then this specific grant just focuses on the Medicaid recipients. Yeah.
Dr. Greenberg?
Thank you, Anne, for a great presentation and overview.
Thank you.
The COVID epidemic has evolved. We all feel like we've lived 8 lifetimes, but it's only been a year or two. And the epidemiology of the pandemic has changed so rapidly, especially in Washington, D.C. How has it been for you at the sort of eye of the storm with access to all these databases, to have changing questions and changing priorities during the beginning, the middle, and now towards the waning parts of the epidemic curve? How has it been to try to keep up with all that? In other words, how have your scientific priorities changed? What have you been able to accomplish that you're happy with? What are some of the frustrations you've encountered? Just doing all this research during a period of such a rapidly changing epi curve.
You know, I think it's really interesting that the initial project looking at whether people were at risk of acquiring, risk of developing severe COVID if they were to acquire the virus, by the time we finally had it ready for publication, we had almost kind of missed the boat on that because cases were starting to come down, thankfully. So every idea that we had, if there was difficulty implementing it quickly, then everything had changed. The landscape shifted beneath us. And so it's making sure that the information that we're getting out is timely and relevant and important. That is a little bit of a challenge, I think. And I'm sure others have experienced the same thing, just because the mechanisms of research sometimes work slower than we would sometimes, you know, wish. I don't know if others have had the same experience, but yeah, I mean, you know, then looking at the encounter data, you know, when we submitted that publication, we were looking at the interval of March to June of 2020, and now here we are already in June of 2021. And again, everything has changed. The vaccine paper and vaccine project, I think that's still very timely and relevant. You know, within my own practice, I have encountered multiple patients who are hesitant to receive the vaccine for different reasons. So I think that will provide some really interesting information. But that would be my comment, that everything shifts quickly, and it's hard to sometimes get things out as quickly as we would like for them to be as relevant as possible.
I'll ask a question while we wait for others to gather their thoughts. So with regards to the data you shared with us, you mentioned that it's on maybe about 40% of the DC cohort population. And the findings still very generalizable, or were there specific types of sites that you weren't getting data from? And so this is really reflecting more the academic medical centers, or do you still have a pretty nice distribution? Because I think that is really the beauty of the DC cohort, that it really does reflect the entire makeup of the care practices that we have in DC.
Yeah, so that, I mean, that is definitely something that I have a feeling the reviewers will ask too. How did the people who were included from these sites compare to the people who were not included? Luckily though, the sites still do represent a relatively diverse population of individuals with HIV within DC, and it's still such a large number that does help us a little bit. But in terms of, like, for example, the encounters and the viral load data, the practices at those clinics in terms of using telehealth and or bringing people in for labs may be different from the clinics that weren't included. And so I think that we can rerun this analysis once all clinics are, you know, even just for our own knowledge, maybe not for publication, but just to see how things change once everybody is included. Yeah.
And I have to say, I was surprised that so many people were getting lab testing, because I did kind of sense an initial reluctance to test, and even a reluctance to order tests by providers during kind of our peaks, and then a gradual kind of getting accustomed to, you know what, this isn't going to go away tomorrow or next week or next month, and we need our safety labs, and I'll mask up and go in. So, but it's good to see that so many tests were still being done to really inform us as to how well people were doing. And I do think it does show such a commitment to, you know, being aware of one's healthcare during this time period, because we know there were a lot of delays in care related to routine healthcare management, preventive services. And so to see that our patients were really committed to continuing to engage in care, I think is really great.
Agree.
Yeah. Any questions from anybody else in our audience? I know we have a really wide spanning audience.
Can I ask a quick question? Sorry.
Yeah, of course.
I was wondering if you got any data or asked questions on how COVID affected them in terms of, like, either financially or socially.
Yes, so luckily that is one of the domains that we captured. So we asked about, did their household income change? Did their work status change? Were they able to work at home, or were they still required to work in person because of the nature of their job? Did they know anyone who had died? Did they, you know, kind of a wide range of topics within that COVID impact. And so we're going to try to look at, you know, within those outcomes, you know, we often know who are the most vulnerable people in our patient population, and we're going to see, and what we expect to see is that those, you know, who are most vulnerable in many ways, you know, were perhaps most strongly impacted by those different facets of the pandemic, you know, and we are going to be able to eventually tie that to their HIV outcomes as well. So again, I think the only limitation we have right now is our speed. How quickly can we get, you know, this information collated and analyzed? And you know, we do have all those pieces of the puzzle. It's just a matter of pulling it all together.
Yeah, great. Thank you. It was very interesting presentation and very interesting data. And yeah, we were wondering about this. When COVID not only impacting people at the individual level when they get it, right? Or when they lose a job, but it also could be somebody else in the family getting COVID or losing a job. That will also impact people. So I'm glad to hear you covered that.
Thanks.
And I think too, and I think not, I know we always feel like we're chasing our tails and it already, someone did something already, but honestly, I think even as we transition into this next phase where maybe COVID levels have dropped, but the support services that were put in place also are changing. You know, the bottom hasn't dropped out for many people because we've had so much support, and that's going to shift and change. And that may, you know, housing may, you know, people no longer having rent assistance, food assistance, etc. That could really change things a lot as well. So,
Right.
you know, I think that, you know, repeating these surveys and even having that, you know, during pandemic, some security blanket, and after, yeah, COVID was there, but the security blankets were also there. And those are, I think, going to be so critical for us to make sure we can, for us to use as advocacy pieces and to use them quickly so that, you know, the continuum doesn't fall apart. People continue to do well. Because I do know that just generally speaking, that's a really big concern for a lot of people, is what happens next when, you know, restrictions are lifted, you know, masking rules, regulations are changing, but also the economic support is also going to start shifting. So I think a lot of it remains very relevant.
That's a great point. And we have not talked yet about doing a follow-up survey, but I think that that's a perfect justification for why we should go back and talk to people, or, you know, interview or survey people again.
Right. Yeah. And that baseline always becomes a good starting point. But I think that next time point, having a baseline, even if it's not published already, you know, gets incorporated into that more longitudinal. And I think it's really important to capture. Anybody else with questions, thoughts, comments?
I have another comment, although Sam, were you about to say something? No, okay. And actually, Sepale, your conversation sort of reminded me about long COVID. And so and I wondered as you were looking at the diagnoses, is there ICD-10 codes for long COVID yet? Is that something, is sort of understanding that among persons with HIV in the cohort, something that would be better captured in a survey, or better, you know, if that's evolving, or if it can be captured with diagnoses?
That's a great question. And to be honest, something that I haven't looked into yet, but I think that is a perfect use of the cohort because people are being followed over time. And, you know, I recently listened to, wasn't it Steve Deeks they're doing a long COVID cohort. I can't remember if all those people are also HIV positive. Does anyone remember that from a recent, but I think that's a great idea and certainly something that we could do within the cohort. Yeah.
Dan?
So,
hello. Hello.
Can you hear me? Can you hear me?
Yes, Sam, we can hear you.
Okay.
And Miss Yvette, we'll get you next.
Okay.
Okay.
Oh, sorry. I was just going to follow up a little bit there, which is, and are you thinking of at this point sort of planning for sort of a very long-term follow-up of these patients who are infected with COVID in the DC cohort?
So it hasn't been a topic of active discussion yet. I think this is, you know, one of the reasons it's so good to be with this group is that, you know, we are a collaborative team and, you know, invite not only our site investigators, but also others who have specific interests. You know, the beautiful thing about having a resource grant is that it's a resource. So, you know, we have not made specific plans yet, but would certainly be open to that and open to working with investigators who are interested in that specific topic.
Miss Yvette?
Yes, I wanted to ask how serious or dangerous of persons living with HIV if they get COVID?
Yeah, so thank you for the question. You know, the data is somewhat mixed. So we know that individuals who have severe immunosuppression, unfortunately, are more likely to develop severe complications of COVID. And individuals who have multiple medical comorbidities in addition to HIV are at higher risk of severe complications from COVID. So with those facts in mind, you know, unfortunately, even in the presence of vaccinations, you know, there is still a possibility that individuals with those risk factors could develop severe COVID, you know, and so certainly vigilance is still required for people who are at high risk of those severe complications.
All right, thank you.
Sure, you're welcome.
Oh, and hi, Sybil.
Hi, Yvette. Any other questions for us? And I think Ms. Yvette, in addition, you know, this does raise the question. I know a lot of our patients are very concerned about mask use and kind of personal protection. Does the vaccine give them sufficient immunity that they are, you know, that they should throw off the mask? And it's really a difficult time for people to kind of adjust even to COVID easing and going away. And of course, all of us are ecstatic that the numbers are much lower, and that's protective for everybody. But there are, you know, there are so many questions still around that, and how that affects people's behaviors, and also how it affects either the social, how people socialize and mental health. So it's really good that you're capturing the additional data with, you know, additional surveys that usually would not get captured in just a medical record outside of just free text, which is hard for you to get into the DC cohort data. I think you have a really beautiful, nice, rounded project that's ongoing that really gives us a lot of insight, both to HIV and now to COVID among people living with HIV.
Definitely.
Any other questions, thoughts? Otherwise, I think we gave ourselves an hour, and I'm glad we did, and we've had a good amount of time for discussion. Any last thoughts, comments? Otherwise, we'll let Anne or Dr. Greenberg have the last word on and wrap up for us for today.
I just want to say how great this is to be sort of a clinical group within the CFAR having these conversations from this angle. And I mean, I haven't seen Lakshmi or Deborah or Sam or Leah in over a year. So it's so good to see you again. And I really, as a clinician myself, I thank you for having this group. I intend to be regular. Thank you, Dr. Kasai.
Yeah, thank you so much. And Anne?
Yeah, and my only other thoughts are, you know, I love talking with people about their research ideas and new projects. CROI is coming. This is a collaborative project. It's a resource, and so please, you know, we have a new analyst who started with us. So in addition to Morgan Byrne, who many of you have worked with, we have recently hired Shannon Barth, who actually worked in the VA research group for years before she got her PhD, and is moving into HIV research, and we're really thrilled to have her. And, you know, of course, the other big change this year, over the past 2 years, has been working with the GW Biostatistics Center, and we're very excited about that too. So, you know, please bring projects, ideas. We can work through them and try to find successful collaborations. That's one of the reasons I was really excited to come and talk today, is because that's what keeps the cohort going, is the ideas that people bring us and we work on together. So thanks so much for the opportunity.
Yeah, thank you. Thank you, everybody. Thank you so much. And everybody have a nice rest of your day.
Okay, take care.
Okay, thank you.
Thank you.
Thank you. Bye, everybody.